Right, I can see it's starting to settle down a bit. So let's start to kick off, and then we can welcome people as they come in. I'm Jenny Reindorp. I'm Interim Director of Programmes at NHS Providers, and I'm really delighted to welcome you to this latest in a series of virtual events that we're running as part of our provider collaboration programme, which aims to share good practice and emerging learning on provider collaboration hot topics, really focused on board members and programme directors. And today we are focusing on the very topical and pressing challenge of how providers are seeking to work with one another to reduce care backlogs across the system through provider collaboration. Obviously, we're thinking about acute mental health trusts and community in that context. And we're going to hear this afternoon from two different sectors and systems. Firstly, from the Lancashire and South Cumbria Provider Collaborative, and I'm going to be delighted in a minute to introduce Carolyn Forrest, who is Programme Director for Elective Recovery, and Gary Doherty, who is Director of Strategy and Planning. And we're then going to hear from Danielle Oom, who is Chair of the NHS Coventry and Warwickshire Integrated Care Board, who was also until very recently Chair of the Birmingham and Solihull Mental Health NHS Foundation Trust, so she also has experience of leading provider collaboration in the mental health sector in West Midlands, but today she's talking from an ICB perspective on the role that collaboratives can play as part of wider system-wide efforts to reduce care backlogs. And Danielle is going to be speaking alongside Laura Nelson, her Chief Integration Officer. Before we dive in, just the usual housekeeping. The presentations are going to be recorded, so please have your microphones muted while others are speaking. We will circulate the slides afterwards, so don't feel you have to scribble away. Do feel free to post any comments and questions in the chat box. They'll be throughout, but there'll be dedicated time for Q&A after each presentation. And if you're able to have your camera on, that's always really nice for speakers to be able to see who's in the audience. And again, if you'd like to come in and ask your question in person, that would be great, rather than popping it in the chat. But yeah, very much welcome you coming on camera to do that. So without further ado, let's dive in, and I'm going to hand over to Carolyn, who's going to kick us off, as I said, from the Lancashire and South Cumbria Provider Collaborative. And thanks very much, Carolyn.
Thank you very much, Jenny, and sort of virtual hello to everyone on this webinar. So my name's Carolyn Forrest, and as Jenny has said, I'm the Programme Director for Elective Recovery, and I work within the Lancashire and South Cumbria Provider Collaborative. Almost as a sort of a warning before I go in, I'm 7 weeks into this role, but this is the programme which has been going for several years. So I in many ways, I think I'm having the pleasure today of telling the story of my team and my predecessor. I am hoping to be joined by Gary Doherty, who in many ways is the founder of the programme. So yes, it would be really lovely just to share some of our reflections. So we move on to the next slide. Thank you. So just really quick sort of orientation. So Lancashire and South Cumbria Provider Collaborative. So we are based within the Northwest region. And we comprise of 5 trusts, 4 acute trusts and 1 mental health and community trusts. And in terms of the acute trusts, they're actually generally quite equal in size. So that sometimes that I think makes things well, it brings some challenges, but actually some easy sort of coming togethers as well. And here I've just sort of shared, if you will, some of the principles, the ambitions of the collaborative. I'm sure very similar to other people on the call, but real sort of ambitions about that equity of access. We want, equity about how our staff experience the workplace, and a real excitement and ambition about doing things as one and recognising the benefits that brings. On the next slide, it's just a visual around our vision. If we move on to that, please. Thank you. So again, you kind of see in the centre, I say that overall sort of vision about working as one, some real sort of principles of how we work together, and then sort of 4 quadrants: high quality services, financial sustainability, happy, resilient workforce, and best health and well-being. And the space that I occupy in elective recovery very much, I think, cuts across the high quality services, and it's explicitly called out in terms of the strategy there. But it also, for me, works across the best health and well-being when we're talking about, supporting colleagues and standardising the work that we do. So we move on to the next slide. I'll do a quick sort of context around our approach to elective recovery, and then I'm going to get into the tangibles and share some examples and some reflections. So as I said, this programme precedes my time in this role, and it was set up in the summer of 2020. And very much, the national planning guidance was landing. We were still very much early coming out of the first wave. It was to provide that support to all of our acute colleagues on the key actions that were being asked for, to provide that direction, but obviously critically approach that in a collaborative, system-wide way. And I think it's very fair to say it has evolved and it has grown since that time. As I understand in the archives, it was Gary and our colleague Gemma, who's our managing director for the Provider Collaborative, in a room going, we've got to put something here. And I think for a long period of time, there was my predecessor, probably as a single person, sort of establishing initiatives and programs of work. So it's definitely evolved. And, I think with sort of a change of any personnel, we always sort of take that opportunity to sort of review and refresh. So we're currently just refreshing the programme. And I think that's because we're now in a place where I think we're able to stop being so reactive and be able to move to greater focus on that transformative stage of our programme. So just one further slide, a couple more slides just on the programme before the tangibles. Move to the next one, please. That's just an overview of, if you will, the kind of strategy and the framework that we work to. So we have our overall sort of monthly group, as we call it, where we bring our key stakeholders together, COOs, medical directors. And then we have 6 work streams, or 6 areas of focus, as I sometimes refer them to. And these are the areas that we do our programmes of work and initiatives to achieve our overall aim of reducing our waiting times for residents in Lancs and South Cumbria. And we also have an infrastructure of a number of different clinical networks who very much sit underneath all of our various programmes. And our clinical networks are really critical enablers, and they can have views and help sort of support change within theatre productivity and high volume, low complexity metrics, as they can in terms of, getting involved in more strategic things around, pooled capacity, single site, etc. So they play a critical role. And then just lastly, for me, sort of some of the principles when we come together on a system, collaborative level around a programme. So what's the principles? What's the space that we occupy within the programme? And for me, it's about where we have a shared challenge, where there's a shared problem that any acute has, that's the space we come into to make sure that we maximise the benefits of doing things once rather than 4 times. It also is a fantastic opportunity to allow that sharing and rapid rollout of examples of good practice. People have different skill sets, different things they bring actually to the collaborative approach. And we're very keen, obviously, to standardise delivery where that adds value and makes sense to do so. So moving on to, I think, some sort of reflections and some tangibles. And the first, and I suppose the main one I probably am going to focus on, is the work that we've done around mutual aid. The mutual aid, I think, that was born out of all of our responses to the pandemic, but really getting into mutual aid in the elective recovery space. Now, the purposes of this graph, and apologies, I'll try and quickly orientate, is to illustrate, I think, at the beginning of this financial year, the different level of challenge that our 4 providers started with to eliminate 104-week wait. So the black line is one of our providers. And you can see they started off the year with a considerable backlog. And you can see very sort of far down, you see a blue, and you do actually see an orange, and you can see a green line. But that's just to illustrate, we certainly had differing sizes of mountains to climb in that regard. And that very fact drove us to quickly put into place some process and mechanism to be able to transfer patients across the 4 providers, and if you will, almost look at our capacity in a more pooled sense. So what did we do? There was a standard operating procedure put together to, obviously describe how it would work, what patients could be pooled, what would be the mechanism of contacting patients, decisions being made around viability of transfer. And since April, we've had a weekly meeting, primarily with operational colleagues. And the process works that it's very much instigated by the provider, who will come forward and say, I have a pressure in X, I have a risk at that time to 104 weeks for Y. And they will begin to say, it's this number of patients, it's this nature of procedures. And the other three providers will collectively go away and quite rapidly consider whether they're able to help. And the reason I say they'll consider they're able to help is what we're not trying to do here is pass one problem to another provider. It's genuinely trying to look at it on a system basis. So quite simple, I think, initially. And to give a sense of scale, since we've started that process, we've seen over 1,100 patients not just be transferred, but treated. And I would say at the current time, we've got another 400 patients who were in the process of contacting, gaining their agreement to transfer, and then obviously get into the nuts and bolts. Obviously, in sense of sort of scale, I'm trying to sort of give a scale of what 1,000 sort of looks like for us. I mean, sat here today, that would roughly be about a third of my 78-week pipeline of patients. So it's quite a large volume of patients relative to our kind of open PTLs. And it has evolved. We also include diagnostics, and we include cancer in our mutual aid approach to looking at tackling backlogs. Just moving on to two more slides. We obviously set it up driven by the 104 weeks. And now that's been and gone. We've patted ourselves on the back. We're into a different space. We're into 78 weeks. So we have evolved it. I mean, it was only just 2 weeks ago that we brought our chief operating officers and medical directors together, where we really tried to objectively look at, right, what's the challenges and the potential risk we're facing now? What is our capacity? How do we navigate that? And we're in the process of doing it. But concurrently to that, there's a really, I would say shared ambition that we move away from this being a very reactive thing. And people really buy into and are very passionate about actually trying to tackle the inequity of weights in a longer term. So things that we're looking at is, how can we have a single system PTL? And the reason we want that is it's very reactive. It is based on somebody coming forward with a request, with a problem. And we want to be more prospective and proactive in how we use our pooled capacity. We are looking at actually how we improve the current process, and I'll share some reflections on that. But wider than that, we are initiating a more transformative initiative where we can actually begin to map out what would single waiting lists look like within Lancashire and South Cumbria. What clinical procedures would that be appropriate to do? How will we bring patients with us? And then also be considering some of the enabling sort of factors, such as what will that mean for the flow of money across providers? So early stages, but the ambition is certainly there that what we've started is going to define our future going forward. Next slide, please. In terms of reflections, and I'm sure there might be some questions or some comments, it's critical. This isn't about process. This is about hearts and minds and cultures. And at core of that is there must be trust and openness. People have got to buy into doing this. And I feel actually very fortunate to have come into a collaborative where that is already part of how we work. But I think in a degree of honesty, it's not easy. You know, this is quite a big signalling away from how I think we have traditionally been required to operate as providers. So I think very much at the kind of very senior executive level, you know, I mean, no issues. I think we all understand the operating environment. We're all very excited on the benefits of doing this. But clearly, when we start to get, you know, sort of further down into our teams, with our clinical teams, with our colleagues who are managing waiting lists day to day, you know, we are absolutely trying to all the time bring people with us and make people understand this is the new way of working. We also have to have some difficult conversations. There definitely is a conflict between the expectation requirement to work as one, whilst at the same time, we still have organisations with their own statutory responsibilities, you know, and the two things right now, you know, they are a conflict, and that's just something which we have to be open and we have to navigate. When we do provide mutual aid to one trust that's having problems, the reality is it can actually worsen the performance of another trust. So, you know, these are very open and live discussions we need to have. To do what we do, it does need coordination, support and capacity, both on a programme level, but it does create extra work within providers. So, you know, that can end up being a blockage in terms of that getting out, I mean, down to getting out case notes, but that definitely, you need to go into it with your eyes wide open. And I think the other point that we've learned is it's actually quite difficult to transfer patients to the back end of the pathway. And I know I'm probably stating the obvious to a lot of people on this webinar, but we very much would love to get to a place where we can almost identify triggers far early in the pathway and actually having conversations with patients before they've even had their first appointment, and they've built up rapport with their consultant or their surgeon. And then clearly, I mean, you know, this should probably be at the top of my bullet points. Today, actually, we get quite a good response rate from patients. You can probably see that's evident within the numbers that have transferred. But clearly going forward, we've got something quite big to really be working alongside patients to understand this. You know, and I think, you know, begin to explore some of the barriers, particularly as we are, you know, right in the midst of the cost of living crisis. So that's mutual aid. There's a couple of other examples I thought I would share, but I will perhaps spend as much time on them. So if I could have the next slide, please. I wanted just to very quickly talk about our chatbot. And my reason for sharing this example is about when we have one of our providers to create something new, create something innovative, and then how we then test it, and then it becomes a sort of default collaborative way of doing things. So chatbot uses AI. It's an automated call system, and it was the idea and designed by our colleagues within Lancashire Teaching Hospitals, one of our 4 acutes. And it supports the clinical validation of patients. It allows almost like a rapid throughput where we can contact patients, we have a clinical script, and we're able to establish, I think most importantly, if patients feel their condition is deteriorated, we can take that away from that automated call. We can get a clinician to then review the patient or make contact. But it also allows patients to indicate if they feel they no longer require treatment. And the response rate in that latter category is quite high. So we're currently averaging about 9% of patients who say, I've been treated elsewhere, my conditions have improved. And clearly, as we're tackling the backlog and we're trying to see the wood for the trees, that is an incredibly important part of our strategy in terms of having clean and accurate sort of backlog and waiting lists. So that's a bit of an overview about what the chatbot sort of initiative is. If we can move to the next slide, please. As I've said, designed, originated from one of our providers, and then we piloted it last financial year. And we piloted it across two of the 4 trusts, so it's Morecambe Bay and then in Lancashire, just over about 2,200 patients, and it piloted really well. You know, the early evaluations are incredibly positive, and therefore this year we're now rolling that out across the whole of the Lancashire system, all 4 trusts and all clinical specialties. So I've got down by the end of the year, we'll have contacted about 30,000 patients. It will be higher than that because 2 of our trusts are within the tier 1 category. And as a result of that, we're having to validate further and deeper down into our waiting lists. So just a bit of a sense around, I think, some of the emerging sort of benefits of that programme. And then the last slide, chatbot, if I could, thank you. It's kind of the next steps. And, you know, from an initial idea about doing things in a more slicker way, we're now actually going to standardise and have a Lancashire and South Cumbria sort of pathway for clinical validation, which uses the evaluation and learning from using technology, an automated system, text messaging, and then we can actually get that embedded. And I would probably suspect it might take us another 12 months to have that sort of standardised, evidence-based pathway for the most efficient way of doing that. And then just lastly, I think I've got one more slide of just some other sort of smaller examples and reflections to share. You know, coming together, for me, there's different ways of seeing that benefit. So these are 3 for me. We've created an independent sector coordination group where we get representations from all of the 4 acute providers, and it's sort of administered and coordinated by the programme team. And we've had some really good changes actually in how we engage and work with our independent sector. But the point of this is, as a collaborative, being able to almost together tell the story to our IS partners. Oh, this is where we're pressurised This is where we really need you to be our fifth partner. And then making sure that it's coordinated. So actually all the IS capacity available, we are actually tapping into it as one. But also I think going forward, we're using our collective kind of pressures and knowledge to kind of inform, I suppose, future commissioning of what we want our IS providers to do. I picked an example from our clinical network. So one of our clinical networks is the anaesthetic and perioperative network. So they're now looking at joint policies. This is one of the first ones they've taken through about no one at home policy, again, standardising. And all of that is about making sure that we all follow the sort of best way of doing things, create additional capacity, get greater throughput, reduce our backlogs. And then lastly, as will be a feature in everyone's elective recovery stories, is about increasing productivity. I'm very well grounded. Before coming into this role, all of my background has been within a provider setting. And, that is where the improvement generally happens. It's our theatre teams, our clinical leadership teams that are driving the productivity. But it's these softer benefits where you bring a group of preoperative managers and theatre managers together through a collaborative programme, and you get people sharing their issues, and you get people sharing, well, this is what I did. And, already in the last month, we've had issues with data quality, and our data wasn't telling the same story as the model health system data. And actually everyone shared all of their different approaches, and we've had the national team come in once, and they've spoken once to all of the 4 providers. And we've had a 6% jump actually in our sort of reported activity. It's not real capacity, but it's really important. We've got one version of the truth of the data. So that for me is like a softer, but actually a really important sort of benefit of coming together. And likewise, we have an outpatient transformation board where each provider has agreed to, I'll look at this pathway in rheumatology, I'll look at this in orthopedics. They'll all go away, they'll all go and see, well, what's the possibilities? What did we change? And then we come back together. And actually, it's very clinically led, that as well. So in fact, you're almost reviewing 8 pathways at the same time, as opposed to each person having to go away and almost sort of reinvent the wheel themselves. So I really hope just a few reflections. And as I say, very, honourable. This is, work which I've been very fortunate to come in and be progressing now. But I hope that's been helpful, and really happy to take some questions.
Thank you so much, Carolyn. That's I'm just thinking how impressive that is, you being 7 weeks in as well. And some really, I think, a very compelling articulation of the kind of principles and the rationale for collaboration, and how you're really beginning to build a lot of momentum, and very powerful examples of sharing practice across the trusts and doing things once. Yeah. So that's a fantastic start. Thank you. I'm going to pick up a question that's been posed in the chat to start us off from Philippa Tucker. I'm going to read this out, but Philippa, do feel free to come in as well. I think it's a great question. So how have patients responded to this, given your point, Carolyn, about bringing patients with you? So how have patients responded given the geographical distance between your different sites? It'd be great if you could elaborate on that.
Yeah, I mean, in the main, very positively. And I won't necessarily reference where I've come from, but I myself was quite surprised when I came into this system, because that wasn't my experience in another ICS. I don't have the exact figures, but some of this is a bit of gut. I think we're probably getting, depending on the test and the specialty, up to about 60 to 70% of patients who are contacted saying, yes, I'll move. We are, it's people who live in Lancashire. Yes, there can be really long distances, not necessarily mileage wise, but you've got some very rural areas. So sometimes a 5-mile journey can actually take quite a long time, depending on where you're located. We have tried, without wanting to overcomplicate it, we do try and use a bit of logic. So if it's patients in Lancaster, if it's a Lancaster service that's struggling, we will try and use a bit of logic and say, well, let's offer Preston. But I mean, clearly, it's not quite as nuanced as that. But overall, really good. We're not finding at this point, any complaints about it. So that's the one thing. I don't think people feel aggrieved, because it's very much seen this is for you to decide, and it's about supporting and empowering. We do try and sort of myth bust and try and create that trust with patients as well. But we haven't yet gone into the territory of we'll cover your travel expenses. I suspect we'll have to get into that and understand any financial implications for patients. But at the moment, there's nothing escalating through as a really strong theme where if we could look at some sort of budget and pot for this. So overall, I think really positive. We have very good relationships with primary care. And whilst I can't evidence it, I suspect probably that good sort of general partnership working will be easing some of these conversations as well.
Great answer, Carolyn. Philippa, would you like to come back on that?
Yeah, I mean, that's very helpful. Thank you. I was just thinking, obviously, I am from the NCL and North Central London area. We've done lots of mutual aid in a very similar way to reduce our 104-week waits, but that's obviously a very different issue than trying to move people around. I know your area a little bit, and just thinking about the geographical challenge of that. So yeah, if you do have any feedback or actually evidence regarding health inequalities as well, and also if I can just sort of finally flag the difference in the type of operations or procedures that you're talking about, because I'm thinking if it's a fairly standard procedure, obviously you can move people around, but if you've got specialists, how have you been coping with that? So to get that 104-week wait down to 0 in that time is obviously really, really good. But don't want to hog the floor.
Yeah, that definitely is one of our reflections. So this works when it's more simple cases. And I think, when we started, we probably lost quite a few weeks talking about, colorectal patients and reversals. I mean, that's just, the clinicians do quite rightly don't want to play in that area. That's not the right thing to do. So we've had to learn that as we go. And now I think we're far clearer from the clinical sort of appropriateness and where it's appropriate to transfer. Sometimes we do not transfer patients. So if it is complex, we can look at transferring staff, and we have done that, transferring equipment, and when we've got fallow theatre space. So there's other ways to get around, I think, when we're getting into the more complex cases that, clearly are going to be a risk to our 78-week position.
Thanks, Carolyn. I'm just going to hold that point perhaps on health inequalities and loop back to it. But Ben, Ewan, nice to see you.
Hi, everyone. Hi, Carolyn. Thank you. That's really interesting. Just building a little bit on the point you touched on in relation to transport. So I'm from Bain Swindon, Wiltshire area, which is a fairly rural place. It's about an hour between our 3 DGHs. And we're interested in exploring whether it's the practicalities of staff, patients, equipment moving around. And I was wondering if either you, Carolyn, or anyone else on the call had experience of thinking about different forms of transport to enable us to, in particular, avoid exacerbating inequalities in the system that we think really would be a risk, without us doing something tangible alongside a proposition to potentially move activity around. So any lessons or any thoughts on that from anywhere else?
Yes, I was going to say, I wonder whether there is anyone else, because I do think I'll be very honest, we've not got into that space yet. And it's really important to get into that around the health inequalities area.
If anybody else would like to come in, do raise your virtual hand, or if you've got something that you'd like to pop into the chat. David.
Hello.
Hi.
My name's David Williams. I'm Managing Director of the South West London Acute Provider Collaborative. Nice to see you all. So, Colin, really impressive mutual aid numbers there, and well done for what you're doing up in Lancashire. Just a couple of questions, really. We're at the same space, really, in terms of saying, well, we need to get into joint PTLs so that we can reduce the health inequalities or the capacity gaps that we've got across the patch. So I'm interested, firstly, about how far along that journey are you, one, and secondly, and I'd be interested for colleagues as well, we're sort of getting into discussions now about, well, actually, is the model of care we've got for surgical services sustainable? So we'll be doing lots of tactical stuff, as you've been doing. But now we're thinking, well, okay, where are the subscale services? Where's the pattern of services going to be that is both financially sustainable and better for patients going forward? And I just wonder whether again, colleagues on the call or yourself have got into those types of discussions here? Thank you.
Thanks, David. Great question. Carolyn.
Yeah, I'm really happy. In terms of a single PTL, I think we're in the options appraisal. I mean, we do have some data. We have a CSU that pulls together sort of minimum data set. So I can see, a very high level where I think we've got inequities of waiting times, but it needs to be at patient level. So we're talking about, can we develop that in-house or do we buy something in? And then we'll get into the whole IG domain. But I think your point about model care is really important. I'm glad you've raised that question. So I sit leading the programme of work around elective recovery, which is a bit more here, now, live. But I work very closely with the programme director, which we will title our clinical strategy. And that's absolutely that point. So where have we got services, which we might call fragile, or certainly let's call it sustainability, where we are wanting to get into that sort of networked model. So what happens everywhere, what maybe happens in a couple of places, what is right to happen, just in one centre, because that's the right thing to do for clinical outcomes and for sustainability. And I think for both of us, we really understand that the elective recovery programme, whilst that's happening, there will definitely be a point where we kind of definitely link together. One will overtake the other. So it doesn't sit in my world, but I absolutely do link into that wider strategic piece around, it's all very well sharing dermatology patients. We have a problem with dermatology. And we take a lot of that through the clinical networks. But we're going to be too, maybe I'm being a bit now negative. These kind of changes do take a good couple of years to do. But here right now, we need to do something to step towards that.
Thanks, Carolyn. I'm just checking if anybody else wants to come in at this point, or whether there's anything in the chat. I mean, there was something that Carolyn I wanted to ask around, you were very clear about this being about hearts and minds, not process. And it's a big cultural change to be thinking of care backlog system-wide rather than at a trust level. And I wondered what you found is helpful in that kind of OD piece and that getting that kind of cultural change to be embedded across the trusts.
Yeah, this is where I speak probably with a little bit less authenticity, because I wasn't here from the beginning, but slightly smaller. I think being slightly smaller with 4 providers, if I'm going to be honest about some of the conditions, I think makes this easier. COVID, so I'm talking about conditions rather than the OD piece, but the conditions there. What's my experience of how we work? We do things with people. So very, very tight networks. The professional networks are really tight. The relationships are really good. So our COOs get on very well. They're able to have very open conversations. The medical directors, there were good relationships. There were good relationships with chief executives. So, and I'm not just saying this for show because there's people listening to what I'm saying, but people have worked hard to build good relationships. And for me, that fundamentally what it comes down to at that level. The next level down, which I referenced to, I think it is something where it does need to be a bit more intentional. So definitely now we are bringing different people and different roles into this space to feel like they've got control of it. So, the business manager of a unit, let's bring them along to a session. Let's them sit in a room with other business managers. But the thing I feel really positive about, because I sort of asked this question sort of week 1 when I met people, how do your teams feel about this collaborative? Do they understand it? And I feel a real confidence that the COOs, the deputy COOs, their leaders, this is now the language that they start to use. So I think some of it is just making people feel safe in the space, isn't it? Making them feel part of it and making them understand the rationale. But I think probably more to do with clinicians. I think that's the tough one. And sometimes you've also got to be a bit kind of just more pragmatic. Sometimes people got to feel like they've got something back from it as well. I think it sounds awful. I said this to somebody yesterday. I went, it's quite good now that you're struggling. And they sort of looked at me blank and says, because now somebody else can help you. Whereas actually in the last couple of months, it's been you helping somebody else. So, I think some of it is we're just all human beings at the end of the day, aren't we?
Absolutely, Carolyn. There's really good reflections there, and particularly on the importance of clinical leadership and engagement. I'm going to take one more question before we move to our second case study, and it's just a reflection really and question from Ben about the role of clinical networks in balancing short and medium term priorities. Ben, do you want to come in on that point?
Yeah, thanks, Jenny. So I'm really struck listening to the presentation and the conversation about the parallels with our work in BSW, and I'm sure everywhere else too. One of the things that I think I'm personally wrestling with and thinking about how to work with clinical colleagues and transformation colleagues is balancing the sort of short-term elective recovery and then the much more developmental thinking together and developing different ways of working, integrated ways of working, within systems. And so I'm really interested if there are tools or toolkits. We're trying to develop one ourselves, but I'd be interested in sharing our thinking and some sort of exchange with colleagues, if that's possible. You must have materials, Carolyn, that you're using.
It probably is that maybe I just haven't quite uncovered and put my finger on, still being so new. But yeah, it'd be really good actually to link up maybe after this webinar, because we're all thinking the same things and working through the same matters.
I wondered, Jenny or Bobby, if that's the sort of thing that we could reflect on in one of the kind of workshop type sessions that that you've been organising. That might be a really interesting subject for a number of us.
I think that's absolutely right, Ben, and a point well made. And we'll take that away. How do you do short-term, address short-term recovery imperatives while keeping those longer-term transformation ambitions in mind? Not an easy task. And Ben, if there's anything you've got to share on the work where you've got to with the Alliance, do pop that in the chat, but we'll come back to that. So Carolyn, thank you so much for all that you've shared there. It's just fantastic progress, and also thank you for being so open about the challenges as well. I'm now going to hand over to Danielle who chair NHS Coventry and Warwickshire ICB, and Laura Nelson, Chief Integration Officer, who are going to give a perspective, an ICB perspective on the role that provider collabs can play in tackling care backlogs as part of a system-wide effort. So over to you, Danielle and Laura. Thank you.
Thanks very much, Jenny. So my name's Danielle so I'm Chair of Coventry and Warwickshire Integrated Care System. And that is part of the Midlands, very close to Birmingham, Solihull. It is quite a diverse area geographically and also in terms of the population. So, just a few sort of stats to give you a sense of the place. This is 2011, I think, census information. So things have moved on a little bit since then, but Coventry is about 33% Black minority ethnic population, and Warwickshire is about 92% white. Coventry has generally got a younger population with an average age of just over 32, and Warwickshire has an ageing population with 21% of it aged over 65. We've got predominantly urban Coventry and predominantly, but not totally, rural Warwickshire. And of course, within Warwickshire, we have a northern part of the county that has got quite high levels of deprivation as well. In terms of our providers, there's also diversity. So we've got 2 DGHs in Warwickshire that work together as part of the SWIFT group. And in Coventry, we've got a tertiary provider, UHCW. In terms of the local authorities, they work really well together and with the NHS, but they are of different political colours. And in Coventry, we've got City Council, and in Warwickshire, we've got 2 tiers, county and districts. So there's a lot to bring together to make things work, but we're really committed to doing that in the interest of the population we serve. And we're really clear that we will work together at system level where we can drive economies of scale and better meet the needs of our population, whether that is making more sense of patient pathways through driving collaboration, and also by working together at place, locality and neighbourhood level collaboratively too, where we can do so effectively to bring decision making closer to the populations we serve. So in terms of, so that's the backdrop for our presentation today. In terms of how collaborative working across providers has been beneficial to date, it's been a key factor in our relative success in terms of elective recovery and the comparative positive reduction on waiting lists. I caveat that because obviously none of us are delivering at the level of in terms of waiting lists that we want for our populations, but comparatively speaking, Coventry and Warwickshire has made a lot of improvement, and that is really down to the successful collaborative working across the providers. So our ambitions for collaboratives going forward bring on this relative success and take the essence of that good work so that we can further reduce our waiting lists and improve services, and do that whilst maintaining our focus on prevention and tackling health inequalities. Now, the person that's been leading on this integration work is Laura Nelson, our Chief Integration Officer. And Laura is now going to talk you through some of the detail of the work that we've been doing, and also some of the patient benefits we're starting to see. Over to you, Laura.
Thanks, Danielle. So I'm Laura Nelson, the Chief Integration Officer, as Danielle introduced me. So just building on that, and I think listening to the previous conversation, so we've done quite a lot of collaboration in terms of collaborative working, but I've just pulled some slides to kind of show the next phase that we're working through in terms of putting in some of that formal governance to give us the headspace to do more of that mid to long-term strategic planning. So if we can just go to the next slide, please. So the first thing that we identified was obviously around how do we transition across a number of work programs through the kind of consultative forum, the 3 phases linked to the commissioning agenda. And it became very apparent that actually we can't do it all in the same way. And actually for our system, it's more beneficial to do it slightly differently. So for urgent and emergency care and out of hospital and continuing healthcare, we're actually in stage 1, which is the consultative forum in terms of that process. But on some of our other pathways, we're working through what that means aligned to that roadmap. But urgent care seemed further ahead, and we were more aligned in terms of that collaboration with the right infrastructure in place. Next slide, please. The other consideration that we discussed as part of that was actually what is the resource implications and what will that mean, not only for the ICB, but the whole ICS, and how that will reflect in terms of each individual provider, and how do we work collaboratively through the right governance structure to get us through that kind of commissioning piece. Next slide, please. So this, and this is very much proposed. So as I say, we have done a lot of collaboration, which I'll get onto further in the presentation. But this is kind of our proposed governance structure around how we bring it together. So we have 2 different care collaborative groups that will bring together 4 places. So we've got 3 places that sit within Warwickshire and then 1 within the Coventry agenda. That does get slightly more complex when we start to talk around acute care provision, because the tertiary centre currently covers Coventry and Rugby, with the district hospitals picking up some of that provision. So it is quite complex for our system. And then alongside that, we've then got provider collaborative, so primary care, acute provider collaborative, and then mental health collaborative. And then we've developed a system-wide program board where all of that will feed in. So there's actually true oversight from an executive level looking at each piece of work. So you're getting the view from a kind of specialist area, whether that's acute, primary care or mental health, but also considering neighbourhood, place level developments and allowing both of them to work alongside each other as we move forward. Next slide, please. So in terms of the actual specific provider collaborative, so we have got a mental health collaborative that isn't in the consultative forum stage. It's very much around collaborative working and talking through kind of the immediate pressures that we've got in the system. Next slide, please. And the same on primary care, obviously got a significant agenda in terms of moving that forward. And I think the piece for me here, specifically on elective recovery, and there's lots of debates and discussion around primary care, whether it's in or whether it's out. And for me, unless we start to do things collaboratively with primary care and look at access and actually link to inequalities, people that actually aren't accessing, then we're never going to recover the position. We're just going to do the short-term fix. So actually, how do we support that primary care collaborative but allow it to have a voice on the acute care collaborative? Next slide, please. So in terms of the acute provider collaborative, so this is very much in the formation in terms of governance, but we have had a provider collaborative in place in our system since 2011. And I think similarly to the previous conversation, what that provider collaborative has always done is if we've got an issue or something that's being escalated, it's brought people together to have those conversations, where we're trying to reset these collaboratives now to look at actually what is our strategic vision and how do we take that forward. So these are linked to the ICS objectives and then what we feel are our priorities in terms of moving forward. Some examples of that future-proof are around clinical service recovery. So actually looking at where we've got significant pressures across a specific service and actually doing an end-to-end pathway review. So actually, where is it appropriate to deliver that care? Where are we seeing patient populations and increases in referral? What are our clinical and quality outcomes? And actually, what does that look like for a patient? What's the transport infrastructure, etc.? So a whole piece around actually a challenge specialty, but an end-to-end from even from prevention, I suppose, to actually receiving treatment. So that's some of the things that we're starting to move forward. Next slide. And I suppose just in terms of key successes, so I get all the previous slides are kind of the governance piece and the formal bit that we're trying to now put in place. But in terms of what we've delivered through collaborative working, and I suppose, so we've got an elective care delivery board that's been in place since the accelerator. We've had 104 weekers since March. We've got a 78-week trajectory that gets us there by the end of March, and we are offering mutual aid PAN system. We have got a system-wide PTL in place and have done for over a year. And I'm happy to share how we did that and what that looks like. That is at specialty level, tracks by average weeks wait by each provider, looks at the number of patients waiting. It looks at IMD profiles so we can see if we've got a challenge in certain areas. And it's very useful in terms of predicting or seeing where we've got operational pressures in terms of that capacity and having those conversations, which similarly to the previous presentation, we run through a deputy coup group and then through a formal elective care delivery board into our transformation board. A number of pieces of work that we've done with primary care, but one particularly is around gynecology. So we identified that actually we had quite a large proportion of patients that pre-COVID would have been seen in community hubs or within the GP practices. So we used a triage forum. So within one of our acute GPs reviewed a number of those patients and then pulled them back out off an acute waiting list and moving them into community provision. And then we also have set up at the same time a triage for new patients to go into those clinics. Continue obviously with outpatient transformation. So we have an outpatient transformation board, we have a theatres transformation board, and then alignment to give. And again, similarly to the previous presentation, we have different organisations where we've got the clinical and operational engagement that pick on certain areas, and then they pilot that and bring that back through. Another area from an ICB perspective that we're looking at is where we've got a variety of contracts that have been in place pre-ICB, so where we've had different commissioners in place. One particular example is dermatology. So we had a variety of community services across the system, and actually inconsistent waiting times and access. And we hadn't managed to implement teledermatology. We've now got teledermatology in as a pilot and are looking to roll that out across the system. And we're currently going through a procurement process in terms of having one community-based teledermatology pathway that everyone can access across the whole of our system, rather than varying contracts at each local place. And the final bit is just around so allocation of capital. So we've started to have conversations around, well, what's appropriate based on demand, what are our profiles, and how does that link into the inequalities agenda? And we've been quite successful in terms of managing that at system level, in terms of what, how we access national funding, but what does that look like alongside a number of our agendas. So Danielle, I don't know if there's anything else you wanted to add finally.
No, not really. I mean, as you can see, as Laura's described, there's quite a significant amount of work happening in this space. Our ambitions are for this to continue, but to really make sure that we stay aligned to all 4 of the ICS priorities as we go. So absolutely building in health inequalities and ill health prevention into the work. I don't know, Laura, if you just wanted to just quickly take the opportunity to just mention the work that Kieran had been leading in this, in terms of how we're working on that algorithm to reduce inequalities on the elective care. I think that's a good example of collaborative working.
Yeah, so one of our organisations, I'm sure many of you have probably been cited, have got an inequalities tool that supports admin teams in terms of allocation of capacity. So that's been developed at our tertiary centre, so UHCW. They piloted it first in orthopaedics, and I think one thing that's important to note, I think, everyone's looking at inequalities, but it's not one size fits all. So actually, when you look at the variation at specialty, on some there is benefits of using a tool like that or similar. And in others, there isn't that big a gap. So for example, in orthopedic, I think there was a 6-week gap when they implemented, and they've reduced that now. I think it's down to a week. We looked at dermatology as part of our review of the service, but actually the gap wasn't that big. It was about 2 weeks. And we are looking at how we roll that out across the system, and obviously working through some IT and informatics challenges. But actually, I think there is value add in terms of doing that at system level. And as I say, in our PTL, we do track that on a weekly basis. So we can see by each organisation, then by system level, where we've got IMD profiling based on our waiting list and whether that's going up and down, and we track that on a weekly basis.
Fantastic. Thank you so much, Laura and Danielle. Really compelling examples of how you're moving that forward, and also very helpful to see those different stages of maturities you see it for the different collaboratives and different pathways. So what the overall kind of longer term ambitions are. I wonder if I could just see who would like to come in. I mean, I've certainly got a question, but David, let me bring you in.
Hello. So Laura, your I have to say the tool that you've got in Coventry and Warwickshire for the health inequalities is a really powerful piece of work. So, and we're certainly having a look at it as well. So, yeah, I'd just recommend anybody to have a look. It's good work. So just a question about delegation. I know that there's been quite a lot of delegation work with mental health trusts, specifically in terms of provider-led delegations for, spot purchasing and things like that. We've been thinking about, well, is this actually relevant for delegation down to acute provider collaboratives for, large amounts of elective and diagnostic spend? It's a bit more complicated in terms of how that's worked through in terms of governance and in terms of risk, etc. But I wondered whether you started to have those, or anybody really, to have those conversations within your patch, because it's the next logical step for acute provider collaboratives to take on that sort of commissioning responsibility, but there are challenges attached to it. I just wondered whether you had any views.
Thanks, David. Great question. Just on the health inequalities tool, think that Philip has also put this in the chat. If it is possible to circulate details, perhaps we can do that in our post-event email. We'd really love to share. It sounds like some great and really important work. So we will, if it's all right, Laura, follow up with you to share that with attendees. So thank you. So on that second point on delegations, Laura or Danielle.
So do you want me to go, Danielle?
No, that's fine. You go ahead.
So on urgent and emergency care, we are in the consultative forum phase. So we have done it on there. I agree with you, David, around the elective care piece. And I think that's something that we're trying to work through that provider collaborative. But one of the key areas that we're looking at is those service reviews. And I think that will start to unlock and open up the conversation. And I think one piece of advice, I suppose, which I'm sure you all do, but something that I've found really useful in our elective recovery is the use of data. So one of the first things we did is we got that patient tracking list and agreement through a lead provider model to share data. So actually, when you're going into those conversations, you've got kind of the GIRF report, you've got the productivity piece, you can see where there's opportunities or where there's variation alongside what your waiting lists are, where there's variation in access, and then aligning that to the inequalities agenda in terms of that patient population piece and kind of our demographic piece. And I think that will unlock some of those conversations. So that's how we're looking to take it forward. I think when all of us, well, for us, I think when we try and go in with what does that look like, we'll get into a conversation around, well, who's the lead provider and what does that look like because of the relationships, whereas actually using some of those datas and those levers around productivity, inequalities, etc. I'm hopeful that will unlock some of that because that's how we've recovered so far. I hope that's helpful.
Thanks, Laura. Can I also just do a shameless plug at this point? We did have a seminar just over a week ago on delegations that we ran jointly with the NHS Confederation, where there was, I think, some really helpful opening comments from Sandra Roberto at NHSE linked to the guidance around delegations, which I think was, raised lots of questions, but I thought it was also helpful. And there was a good discussion on the back of that. And Bobby, I think the recording is on our website, and we will also, I'm just having thumbs up that it is on our website, and we'll also do a summary of the key messages to share. But yeah, just a plug, because I think it was a very helpful discussion. Philippa, can I bring you in?
Yes, thank you. I just wanted to hear a little bit more about the shared PTL. So I'm just trying to think, how does that actually work? Is it shared before you accept the referral? Is it after the referral? Tell me a little bit more how that works.
Great question, Philippa.
So it's done on the weekly returns that each trust submit. So what we created was a lead provider model. So one of our providers gets the returns that are sent in on a weekly basis to NHSE and then pulls it together that looks at, as I say, the number of patients by specialty, average week weights, whether patients have got TCIs, whether they're non-admitted, admitted, IMD profiles on there. I think what else, a clear trajectory in terms of our 104-week position. And then there's like a summary page that details total waiting list size, 52 weeks, the 3 longest waiting patients on admitted and non-admitted. But we used what was already available from a weekly basis and then get that sent. We got that approved through the provider collaborative at chief exec level, which got rid of that IG piece. I think when you try and do the patient level bit at ICB, obviously you then get into a number of issues. So we used a lead provider model, but I'm more than happy to have conversations around how we set that up and what it looks like.
Thanks so much, Laura. I wonder if I could ask a follow-up question on that one, which is the same question to Carolyn about the kind of cultural change piece around setting up that system-wide PTL, and how did you get the kind of buy-in and the kind of clinical engagement to pull that off?
So we gave a clear definition around what the PTL was. So it wasn't around looking at where services are provided and having almost like lead provider things. It was a conversation around actually where have we got a variation in waiting times and access, and how are we supporting each other to deliver the 104-week position. And obviously it's just built and continued on that. And we also linked in independent sector. So instead of the 3 acutes going for after the same IS provision, we were saying, well, actually, this organisation's got more of a challenge in certain specialties, so actually facilitated and coordinated that. But we were very clear at the start around the purpose of that PTL, and then haven't deviated away from that. So it's not around, funding flows or anything like that. It's very much around viewing our patients at a system level.
Thanks so much, Laura. Do feel free to pop a question in the chat or to raise a hand. I did have a question back to you, Danielle, because you're in quite a unique position, having had that view across 2 different systems. And I wonder if you've got comments as a result of engaging across 2 different patches about what you see as a kind of key ingredient for successful provider collaboration, and what you've seen really makes it work when you've got that contrasting experience, Danielle.
Thank you. Well, actually, I did also work in the Black Country when we were at STP stage. So it's a perspective drawn across 3 systems, and relationships. Time invested in building relationships and establishing, a shared perspective on things, and a sense that you can trust where each other's coming from is absolutely vitally important. So if you look at the example of the Birmingham and Solihull leading on the West Midlands mental health provider collaborative, that was actually an evolution of the Vanguard, which was the Merit Vanguard, which was the first, I think it was the only mental health Vanguard at the time. So, I mean, that's going back, 10 odd years. Obviously, we need to escalate it and move a bit faster than that. But really, you do have to invest the time to build relationships and ensure that people can understand and trust in what each other's saying. And that's going to be vital for all of it, because we're going to be making difficult decisions along the way. And you do need people to be able to focus on the patients and the population that they're serving, and be able to somehow put aside organisational interests, which is obviously very difficult.
Thanks very much, Danielle. I'm wondering if anybody else has got anything else they want to ask. I feel like we've had 2 really rich case studies, so I might attempt to just highlight some key messages and give people precious 5 minutes back before you jump onto your next call. I want to thank our speakers very much, because we do really very kind of conscious of how much pressure everyone's under at the moment. So thank you very much to Laura and Danielle. I don't know whether we actually had Gary in the end, but Carolyn, thank you. We didn't, but thank you very much for joining us. I think you shared some really compelling examples of the opportunity and the kind of momentum that's building on collaborating around care backlogs. We're kind of very conscious at NHS providers that we're thinking for care backlogs in acute mental health and community sector and how it affects everybody. So thank you very much. In terms of some of the themes, I think there's been a really strong theme which comes up in every webinar about this, being about hearts and minds, not process. And the operational detail really matters, but really what makes the difference is, as you said, Danielle, relationships, building a culture of trust and openness, and how to get kind of clinical engagement as part of those kind of relationships that you're building, and recognizing what a big cultural change piece this is, and recognizing, as you said, Danielle, there at the end, that this isn't easy, and we're navigating some really significant tensions between the responsibilities of statutory organisations versus that wider system view. I think there's been a really clear theme around how do we do this kind of what's often around reactive kind of mutual aid, and move on to a more proactive front foot approach, where we're trying to align how we manage these short-term recovery imperatives with the longer-term kind of transformation ambitions. That somebody described it earlier this week as rebuilding the plane while it's in flight. So it's easier to say and another thing to try and do, but not moving beyond the kind of short-term fixes to that wider transformation. How we embed health inequalities into all of this work and really make it an integral, embedded part of care backlog recovery. And I think that's been a theme, and it's great that there's a practical tool from all the work you've been doing, Laura, that we can share on that. And I think the other one I noted about bringing patients with us and making sure that they are on board, and some very practical challenges that were flagged earlier around how to do that in a way that also doesn't exacerbate health inequalities if we're asking people to change where they access care. So anyway, that was my attempt, and there are lots of other themes that I'm sure that we could pull out, but we will share a recording. We will write up the kind of key messages for those that weren't able to come today. And if I could just do a quick plug for future events coming up as part of our provider collaboration programme. We've got a webinar on the 9th of Feb on workforce challenges and how provider collabs are helping people address the workforce pressures. So very much another hot topic. And we have a peer learning forum for directors of strategy and programme directors. It's a drop-in for anyone who would like to come along, and we focus on hot topics. We start to say some of the things that are keeping you up at night, but we hope not things that are keeping you up at night, but the pressing challenges that would help, where it would be helpful to hear from peers. We've put a link, I think, to our evaluation in the chat. It would be really fantastic if you could give us feedback. If you haven't got a minute to complete that, just pop any comments in the chat about what you found useful and where else you would like us to focus on in this programme. There's just been, oh yes, and Philip is saying there is an agreement to share details of people within each provider collaborative. Let me pick that up, Philippa, with the team, and we'll see if we can follow that up for you. So thank you very much, everybody, for joining. Really, really appreciate your time this afternoon, and hope we've given you a few minutes back. Thanks all.